So the first piece that we looked at was the new nursing history form, which I think a lot of you are familiar with, and that was a labor of love, I would have to say, by a specific group of nurses, and it was, it was a change that was understood by that group of staff and is still being challenged by other groups that weren't part of that change. So I think that that's the biggest thing. The people that develop it then need to go out and sell it, and you need to find a way to enable them to do that piece. So the nursing form was one of our pieces, and it included standardized risk assessment tools, which was very important in enabling a culture change in the frontline staff understanding that they own discharge planning, and that discharge planning was not something that happened the day I needed the bed. Discharge planning was something that happened the second the patient showed up in the emergency department. And how do you flow through that piece? So it was implementing the Blaylock tool, the Braden scale, the Morris-Fall scale, and the cognitive assessment, all because those are pieces that if the patient fails any one of those is going to make it more difficult to discharge them. It also makes them a higher risk candidate for staying in hospital. And so nursing staff need to understand these tools and need to understand what it means. The second piece was the CCAC communication tool, which has been extremely helpful, and it's that flow of information from the community into the hospital and back again, so that any patient who has services at home, that is actually flowing through. And so Nancy was a big component of that, and it's been very helpful because communication's extremely important. And if you don't know, as Lori spoke about, in the emergency department, what services the patient already has, you don't know whether just upping their service a little bit would prevent an admission to hospital. And oftentimes we start emergency visits as, starting from scratch, like there is no history with this patient. So I think the more information we can share from community to hospital, the better off we're going to be. So with that communication tool, we need to look at a clear picture of the patient's pre-admission status, what are the challenges that are in the patient's home, and then starting that dialogue. And that the bullet rounds, I think, were probably the key component of having everybody standing there. What an amazing concept to have a whole team of people who are providing care stand there and talk about what care we're going to provide for the patient. But it's something that we've gotten very much far away from, and it becomes very, very important. That has actually rolled out through our organization now, as well as we've now started something that we call lightning rounds in the afternoon, where the staff go around and each nurse reports to the clinician and to the charge nurse on what is the goal for this patient for today, what are some safety risks for this patient, and what's the plan of care. And so what it does is really involve each individual staff member of identifying, what am I working on with my patient today, so that care is not about tasks. There's actually end outcomes every single day. The patient whiteboard, I think everybody has kind of seen that, the whole concept of the red, yellow, and green. The comment that was made about every patient deserves to be yellow, I think is something that I'm going to steal back from today, because I think that that's so true. Historically, patients would arrive in our emergency department and end up on the floor, and the conversation from the family would be, so when do you think mom's going to go home? Well, the nurse on the floor didn't think that had anything to do with her. And so it'd be, well, I don't know, sometimes you end up being here for a couple weeks. So everybody would go home thinking grandma's safe for a couple of weeks until you get the phone call that, no, you need to come get grandma today, and it causes this whole concern. So it breaks it down in everyone needing to talk about where are we at in the planning stage, and that whether the patient's in the building for 3 months or 2 days, there is a process that needs to unfold, and what's the next step to trying to get this patient home. So looking at the patient whiteboard, and how do we utilize it, and how does every team member incorporate into that. So then taking the whiteboards to the bedside so that the communication occurs with the family, so that the family start having that conversation. What does it mean that mom's yellow? And what does it mean that she needs slippers to be able to walk, various things. So it's a great communication tool, and it works both ways. It improves the communication from the family back to the team and the team to the family. So that was a really great learning for the staff. So when we looked at what some of our outcomes were, the number of patients waiting long-term care, at the point that the Flo Collaborative came out, we were up to our eyeballs in a million things, inclusive of a ministry coach visit, I think. And Paul gave me the information and said, you know, do you think we should participate? And I said, my team is going to hate me, but yes, we need to participate. Because at that point, if you look at that number where we were at 72 patients waiting long-term care placement, we have 166 beds. That is a really huge number of your beds being tied up with patients who don't need to be in that setting. It's not that they don't require care, they just don't require that type of care. And when you look at that number of patients, it caused havoc throughout the whole building. I mean, we were routinely holding patients in the emergency department, which, you know, Lori made the comment that the docs really don't know anything about Flo. And I would probably say they don't know about Flo is because they don't routinely have admissions in their emergency department. If they had admissions down there, they'd be understanding what Flo was about. If it doesn't really impact you. So right now, we aren't routinely holding patients in emerge. We've had a couple of little blips, but when you look at the number of patients, it has significantly come down. And in fact, Nancy and I were just talking about it, and we have 31 patients today in the building waiting long-term care. That's a significant change. Some of the other measures that we looked, ALC patients discharged from 5 Medical, which was the unit that we trialed on. So this is just, you can just flip through some of these. These are just some of the statistics, but if you look at the downward trend, it was, you know, we had some really good outcomes related to this. The length of stay on the target unit. The other piece that I would probably challenge you on is the fact that when you have available beds, they will be used. I mean, I've been at St. Thomas for 10 years, and whether I had 10 empty beds that day or I had 2 empty beds that day, I routinely would utilize however many empty beds. If a patient could stay for another 2 days, the physicians very oftentimes. So I would challenge you to look at the number of beds that you have and recognize that bed availability will increase your length of stay. So when you're tight for beds, chances are you're going to be working at driving down your length of stay. Quality comes into this, so you can't just do it without any thought process, but very much looking at it and needing some consistency in how you roll it out so that you care about how many patients are waiting to go home today, whether you're not at risk of canceling surgeries and you're not at risk of holding patients in emerge. You're holding to the same standard today as you are going to be on the day that every surgery is at risk and you may not be doing any.